This is the Skin Science Podcast. I'm Dr. Thomas Hitchcock, and here we'll investigate everything skin science and dissect it from a scientific perspective, analyze it from a medical perspective, critique it from a consumer perspective, and give insight from an industry perspective. Hello, everyone, and welcome back to the Skin Science Podcast. I'm Dr. Thomas Hitchcock, and today we have a very special guest, Dr. Jenny Holman. How are you doing, Jenny?
I'm doing great.
And as always, we have
Wow, elevated.
We have regular person,
Wow, I've been demoted.
We have Angela Wilson McDonald.
Thank you for that great introduction, Dr. Hitchcock. I'm thrilled to be here.
I'm just combobulated because you're usually on this side. Now you're on this side. I don't know what to do. And so in the back, we have Dr. Jose Maldonado, Ndashe Kumungu. And I'm always so worried that I'm saying those names incorrectly, but I'm sure you guys would correct me if I was. And then we have Alan, our producer and director. And we are missing Seti, which I'm here. She's in Germany doing great things with cloning sheep or something like that, right? Or something. Anyhow, I'm being silly. She is in Germany. But today we are going to be talking about a very interesting, complex, what's another? Important.
Yeah.
It's something that it's cancer. It's skin cancer, and cancer is something that I think touches everybody's lives in one form or another. And so a lot of people feel a little bit helpless when it comes to this topic because it's one of those things that our body does that we have pretty much no control over, but we do have control over preventing.
That's true. Very
true. And so that's what today we want to talk about. But I wanted to do a brief introduction of Dr. Jennifer Holman. And she received her Doctor of Medicine from the University of Oklahoma College of Medicine in 2004, graduating with special academic distinctions. And during her residency in the Department of Dermatology at the University of Missouri, she was awarded a Women's Dermatologic Society mentorship grant to work on or with Pediatric Dermatology Department at Northwest University of Chicago, Illinois. The way that we know her is that she was one of the founding partners of the U.S. Dermatology Partners and currently serves as the regional president. She is board certified in both dermatology and in dermatologic micrographic surgery. And she founded her cosmetic and laser practice in 2018, the Center for Aesthetic and Laser Medicine in Tyler, Texas. So Tyler is an hour and a half away?
Hour and a half away from Dallas.
So she came
for dinner.
She came here just to be on the podcast, people, on a rainy December or January
day.
Good
Yes.
day. Yes. And so we appreciate you for coming out here. Because one of the things I must say, skin science is our specialty at Crown, but we don't do much when it comes to skin cancer other than for prevention. We know we have sunscreens and such. Now, that being said, some of our research in the skin microbiome has to do with cancer, and we'll get into that a little later. But first things first, the most important thing of the podcast is the puzzle. Because I
was not ready for this.
You don't have to do the puzzle.
Okay.
You just have to humor him, Dr. Holman. Yes. You just have to humor him.
A lot of people ask me why I'm so crazy about puzzles and why it's my hobby. And the reason is because science is a puzzle. When you do research, it's basically just a long, expensive puzzle.
Right.
And so for me, this is relaxing. Because you're trying to do what my brain naturally wants to do, but in a relaxed, inconsequential fashion, because nothing's going to be lost if I don't solve the puzzle in time. But anyway, this particular one is a puzzle from Japan. It's called a Kerakuri puzzle. This is the Bara Bara box, and with the philosopher. And I don't know if you can see that.
He's adorable.
He's a little bitty little doll, and actually. It's a collaboration. Yeah, it's not really that fragile, but I'm sure if you threw it across the room, it probably wouldn't
last
survive.
long.
Anyway, this is the Bara Bara box, and now we will actually move on with the topic at hand. All right. So, Jenny, first, I think what we need to do is, because we always aim to look at things from a scientific perspective, a medical perspective, an industry perspective, and then a consumer perspective. So why don't you give us a little kind of nutshell around skin cancers?
Sure.
What are the kinds of skin cancers? How prevalent are they? That type of an idea?
So skin cancer is actually the most prevalent cancer that we have out there. I joke that lasers and aesthetics is my hobby and skin cancer is my job. So
Yep.
I spend every morning cutting out skin cancer, doing those facial repairs for people who do develop skin cancer, and then I go play in the afternoons with my fun stuff. And so, but skin cancer, the most common being basal cell cancer and squamous cell cancer. Those are going to come from keratinocytes, which you're very familiar with, and then melanoma type skin cancer, which comes from melanocytes. Basal cells and squamous cells, the vast majority that I treat, I cut them out, I sew them up. Sometimes we scrape and burn them or treat them with the cream. Usually they're more of a nuisance than anything. However, melanoma can be a little bit more scary for folks. There's more than just sun involved with melanoma as well. There can be a genetic predisposition also. And so lots of different factors that play into that. But the most common factor for all three types of skin cancer is UV exposure. And that's the preventable part that you were talking about. And
Right.
so that's why we talk so much as dermatologists about wearing your hats, wearing your sunscreen, avoiding the harshest hours of the day with UV exposure, those type things. But in a nutshell, that's what you're looking at. The most common things that we see are basal cell, squamous cell, melanoma. And really, it's about 1 out of 10 folks are going to develop skin cancer. It's very, very common.
You know, that can get scary for a lot of people to hear because cancer, the word cancer in itself, and I'll let Angela answer this in a bit because she just had a long bout with it that she was able to beat it. And so just the word itself can, you know, cause somebody to really react in a certain way. Some people become obstinate about it because they don't believe it can happen to them. I do have a friend that doesn't believe that it's actually real. Like that he believes that the sunscreen industry has invented this whole idea of UV causing cancer. And we'll talk about it in a bit because one of his reasons for that is that he says, well, people get melanomas in places where the sun don't shine.
Right.
And so we know we can get it in the nail bed and other places. So I think I'd like to touch on that a little later. But first, I'd like to hear, Angela, kind of your take on this. You didn't have skin cancer actually, didn't you?
You know, that's,
There's something, all right.
yeah, you're actually triggered something in my mind. So I did have breast cancer, but the pathology after the revision to my double mastectomy showed cells in the dermis.
Oh, really?
Which
So-
we were wondering whether it's because they pulled it out and
It
left
could
it
be
behind.
transposition. I've had skin cancer. I was 24 and I had a stage 0 melanoma. And so
Wow.
mine was in a non-sun exposed areas, but I also lived in a tanning bed during college. In fact, I had like
As
2
many
memberships.
people did
Yeah.
in those days.
They would only-
Yeah.
You
they'd
go
only
across
let you
town and get it to
yes,
go again?
You couldn't go twice in one day. And so I got 2 memberships.
Wow.
And being a college student, I was like, this is my me time. This is what I'm going to meditate. Anyhow, 24.
Wow.
I'd just been accepted into a dermatology residency and diagnosed with stage 0 melanoma. So yeah, I get it. You know, there's some people would think it's not just from UV exposure, but I agree. Your cancer was much more scary. Most of the time, skin cancer is like my cancer, where it was a nuisance. We caught it early, you cut it out, and you're done with it. And I'm smart going forward. And so,
Right.
yeah.
What percentage of patients, what does the data show in terms of the percentage of people that actually get checked for skin cancer?
that's a
That
good
it's
one.
got to be really
Gosh,
low.
You know, the American Cancer Society and the NAA, they both recommend at 21, everyone start getting an annual skin exam. Clearly that doesn't happen. You know, once folks start seeing early precancerous damage, if they have more than 50 moles, those are the times that we're really encouraging folks. I do have some that like just every year come in and get their skin check, and I'm like, you're still perfect, those kind of things. But for the
So
vast majority of
smart.
folks, I would think, I haven't ever heard a statistic, but less than 10%.
Yeah, it feels like that because you just
sure.
don't hear people doing that. So that would be, you know, having been on the other side of it, if I could say anything to anybody, is just be proactive. Don't bury your head in the sand. Do what you're supposed to do in terms of testing and prevention.
So, you know, to that point, when I was younger, because I've always been a little more hypochondriac prone than a lot of my peers. I think when you do any type of medical training, you tend to start reading into things. I remember I took parasitology, and that was the end of a lot of foods, you know, once you learn some of that stuff. But with, you know, I've gone to my general practitioner over the years, and I would say, you know, can we just take this off? Because regardless of whether it's a melanoma or not, I just don't want to have to worry about it. And a lot of the times they shy away from it. And when we were looking at a particular technology at Crown that we were thinking maybe we would get involved with, I saw a statistic that really shocked me, that the number of melanomas that are missed, even when they're looked at by general practitioners, is super low compared to and dermatologists miss a few, but they do miss some. And so this technology was trying to say they get 100% or whatnot. So what is your feeling about the ones that are missed, and how should people navigate that as far as protecting themselves?
So if you're really concerned about a lesion, I always encourage this, not just with skin cancer, but if you're really concerned about something, get a second opinion. Like sometimes it's the practice of medicine, it's the art of medicine. Even I'm not right, I would think 100% of the time. I may not know it because someone's gone and gotten a second opinion somewhere else. But if you're concerned about a spot, go get a second opinion if someone
it's your life, right?
shies away. Absolutely it is. And so knowing the risk factors, like for melanoma specifically, it's that A, B, C, D, E that we always talk about. Asymmetry, the border's irregular. It's got different colors in it. The diameter's bigger than a pencil eraser. But E is the biggest one, evolution. And so if you have a spot that's changing and you're not sure about it, get it checked out. Because like you say, let's take this mole off because I don't want it to turn into anything. Well, melanoma can develop de novo too. So just out of nowhere, you can have a mole that changes, but you can also have a spot that comes up as a melanoma from the get-go. And so taking all of your moles off doesn't mean you won't get melanoma down the road
100%.
Because you can still grow one out of the blue. And so knowing what those risk factors are, but not all of our melanomas play by the rules. I mean, I took one off someone's temple yesterday that is in this sun-damaged area. Like, it doesn't look like anything, but had a sunspot that he thought was changing. Didn't meet any of those criteria, and sure enough,
it's
melanoma.
melanoma.
Yeah, and so, there's lots of different types, and I took one off yesterday that met every A, B, C, D, E too, but they don't always play by the rules. You can have amelanotic melanomas that look like a red spot, things like that. So, it's easy to say, especially if skin is not your specialty. I can see how folks would miss things.
Yeah, and I think that's also, you said a few things that are very important to a consumer, which is, we're not all knowing, right? Nobody, even experts, they're experts because they may know more than the average person, but it doesn't mean that they are going to get everything or know everything. And so we're all just need to be cognizant of that.
Right.
And second opinions that's smart, very smart. I mean, with anything in aesthetics, especially too, it's, second opinions are priceless because everybody has their own point of view, and sometimes it's where they intersect that is,
right.
And
I try as a practitioner as well to make sure my ego stays in check and to encourage folks, like, if you don't agree with what I'm saying, please, for your sake, go get a second opinion. Or if you don't agree with my aesthetic plan, same kind of thing. Go talk to somebody else. And then if you want to come back here and do kind of the plan that I've laid out, great. Because I think it's really important in medicine and in science that we make sure our own egos stay in check.
100%. Doris Day, right? Yeah, she's one of my favorite dermatologists, and her and I over the years have bantered back and forth. And one of the things she taught, I joke with her because she always said to me, once you know better, you can do better. And I thought, that is so wise. And then I found out it was Maya Angelou. And I was like, Doris, you took Maya Angelou's words and made me think that you were so wise. She is wise, but and so it's true though, is that, we can, sometimes it's only because we learn that we can do better.
Right.
And so that's the whole point of the podcast, is trying to get everybody we all want to learn more so we can do better. So why don't we get into a little bit more of the demographics, because I think, like you said, not everything plays by the rules. So just because you're more at risk demographic doesn't mean you're going to get a skin cancer. Right. And just because you're at a low risk doesn't mean you're not going to get one. And that comes into a lot of people, there's this fallacy of African Americans have really dark skin, and anybody of African descent or dark skin type is less because they have the melanin protection. Right. And everybody that's very fair skinned is prone to. Now, there are some probably truths to that, with like redheads, I think, do tend
Clearly, redheads, blue eyes, fair skin, that Fitzpatrick type 1, they do have a higher risk because that UV damage is more impactful in that skin that's not as protected by melanin. But just like we've talked about, skin cancer is not 100% UV radiation. There's trauma, there's free radicals. There's
Speak about the
pollution.
trauma. What do you mean by that?
So sometimes we see like a second hit hypothesis. You've had sun damage over the years. I can't tell you how many times people will say, I got bit by a horse and this spot popped up. But it's just another hit. That if your body can't repair that damage, then it's a hit on top of your pre-existing DNA damage. A specific type kind of even listed in here, dermatofibromosarcoma protuberans, which is a rare tumor. There's a hypothesis there that it can be trauma-induced as well. And so again, similarly to DNA breakage, your body's repair mechanisms come in, and when those repair mechanisms can't keep up, sometimes that's when cancer develops, and you have cells that grow unchecked by your body's normal regulatory mechanisms.
So that's one of the things that I used to tell Angela. What was it I used to say?
I tell everybody now, we all have cancer cells. It's just that your immune system is supposed to be fighting and clearing them. It's when the immune system is down and the result of trauma, right, affects your immune system that your body's not able to clear those cells.
I mean, what is a suntan? It's your body trying to protect itself from the DNA breakage that's happening from UV exposure. And so those are some of your body's mechanisms trying to protect itself.
And that's interesting because I think most people don't realize. You hear people say like, I need to get a base coat or whatever, and I'm like, do you understand that when you get tan, you've already done damage?
I always reply to that and I say that's like smoking 10 cigarettes a day so that you can go on vacation and smoke.
Get your young lungs prepared.
Like, get them ready. So I've been doing that, getting ready to go to Napa. Actually, like last night, my husband's like, "Nope, you need to have one more glass of wine. We're going to Napa this weekend."
Tolerance to get the tolerance going.
Same idea.
Yeah.
Well, I mean, so what would you say to a consumer that because I've told people this over and over that it's like just because you've gotten yourself a little tan doesn't mean you're more protected. If you go out and you don't and you go on the beach for 3 hours and just because you have a tan doesn't mean you can not wear sunscreen or you're going to be any more safe.
Absolutely not. And so you're still going to get some tan even with some of the best sunscreens if you're out on the beach. Angela and I share self-tanner love.
We do.
So but even with, if I've got my self-tanner, my skin may look darker, I'm still very aggressive with both sunscreens and physical protection. My hat's on the beach. Literally, you can see me coming a mile away.
I think
Let's just say that's Vita Liberata, our own, Crown Laboratories product that we're both big fans of.
Vita Liberata.
I have been for years.
Yes.
So I'm similar. I just don't like to go out in the sun. For me, it doesn't seem like it's worth. I've never been really an outdoors person. I think it's more of an excuse for me.
Yeah.
Because I just don't like the outdoors that much. That sounds horrible. I sound like such a nerd right now.
No.
But anyway, I guess for me, when we think of cancer, because one of the things that I studied when I was doing my doctoral work was the association of chronic inflammation and cancer. So in the skin, do we see that similar association with cancers?
So I would say in some degrees, yes, like for squamous cell carcinomas, like in old burn scars or certain genetic conditions, blistering conditions, those type things, we definitely see higher risk for squamous cell carcinomas specifically, and they're much more aggressive when they do pop up as well. And so in those settings of scars, chronic inflammation, chronic ulcers, those type things, those squamous cells can be significantly, aggressive.
So is there any particular habit or topical or anything that people do to their faces that you think contributes to that type of a cancer?
So I don't know if there's anything that we're doing pro-inflammatory wise that contributes to that type of cancer. There's a lot that we do to try to prevent that type of cancer as far as different chemotherapy topicals, different laser or cosmetic treatments, trying to rid early actinic damage, but no product or thing comes to mind with a skin cancer risk necessarily other than lack of sun protection or lack of antioxidants when you're somebody that's exposed to chronic free radicals, pollution, those type things.
So let's talk about antioxidants. I'm going to go off script a little bit here. Everybody loves it when I do that. But it's because in this script, we don't talk much about the microbiome, and that being one of my passions, as you know. So one of the things that is coming up in literature is that there's a lot of examples, and I believe actinic keratosis is one of them, where they've sampled the superficial microbiota of the lesions versus the non-lesional skin and found that Cutibacterium acnes was not present there. Same thing with eczema, atopic lesions, same idea that a lot of people blame Staph aureus for eczema, but what they don't really connect the dots with is, but there's very little, if any, C. acnes
Right.
because they've always thought that was a pathogen as well. And we're learning that that's not necessarily true. So the real question is, what we know now is that C. acnes produces a huge amount of antioxidants. And you're mentioning antioxidants are key to reduction of or association with some of these
Right.
skin cancers. So
Yeah.
I'd like to hear your thoughts on.
Well, it's the reason I tell my patients to put on their antioxidants in the morning, because what they're going to do is to help your skin scavenge free radicals that you're exposed to during the day. It's not a substitute for UV protection. And
Right.
so have them put on their antioxidant followed by a sunscreen, because we're exposed to these free radicals all the time that are also causing DNA damage or DNA breakage that our body's then constantly trying to repair as well. And sometimes we don't. But pollution, overhead, there's some data on even like indoor lighting, fluorescent lighting that
Yep,
may
puts
have
out
some free
UV.
radicals as well. And so it's more than just the sun that we're exposed to that's damaging our skin. People that are smoking around us, that's one of the biggest things that damages the skin and can predispose you to skin cancer as well, is smoking or nicotine exposure. And so that's where your antioxidant helping your body do more than just block out or screen out UV radiation.
Right. So, I mean, for me, that's one of the key reasons why I'm so passionate about what we're doing with BioJuve. And I can say the name now because it's launched now already, but by the time it's going to be several months probably. But, because frankly, one of the things that's really got me thinking is in aesthetics and dermatology, and I'm not trashing this ingredient, but retinoids are a staple right now. And the question though is, what is the long-term use doing to things for us for things like cancer? Because if we turn off oils, we reduce the acnes, we're reducing all of the protection that they bestow on us as far as the antioxidants and such. Plus, sebum itself has antioxidants in it as well. And we're going to talk in our next podcast about the skin barrier, so we'll talk more about that at that time. But I think about this because we have many examples in medicine where we thought we were doing things right, and then we learn a little bit more, and then we do things differently.
Right.
And we're not trying to blame anything. It's just that we know better, or we know more, so we can do better. And so my question is, what are some of your thoughts on? Is there something that you kind of are the same ilk where you're like, I wonder if that's contributing and we just don't know it?
Well, I think that anytime you're doing something that's so pro-inflammatory to your skin that, like, if you can do your Retin-A one night a week and that's it, and that's because it's so drying and tearing your skin up, number one, if you're doing it for aesthetics, that dry, torn up skin,
It's not very aesthetically.
no, it doesn't look good at all. Number two, if you're only doing something once a week, I question what anti-aging benefits you're actually getting from it. And so that's where steering folks towards more retinoic acids that are a bit more cosmeceutical blended is where I tend to steer people, like where
They're gentler.
well, where they're packaged like in larger fatty lipid molecules. So
Okay.
you're penetrating through the stratum corneum and actually getting to where those retinoids have that mechanism of action. Who knows, we may abandon them completely, but I almost always in non-teenage skin where they're super oily or we're trying to fight like sebaceous hyperplasia, those type
Right,
things.
which I have in my whole family.
Yeah,
right?
and
The men have.
that I'm steering folks towards more cosmeceutical retinoids, and usually compounded products too that have more than just
Yeah, right.
retinoic acid in it.
Right. I think it's an interesting phenomenon. I think also as we start to like do things like sequence ourselves, and because we're still kind of in medicine at a place where it's kind of a one size fits all a lot of times.
Agreed.
And so it's kind of, I don't know, it's a little dubious that that's going to be, I think in the future we'll realize we did as well as we could with the amount of
Right.
information we had. But once we have sequencing, and then it's really going to have to be where somebody invests the money to do what is appropriate for any given phenotype, right?
Yeah.
Which most companies won't do because, and I'm not trying to bag on companies. Companies have to make money, and if they were
Right.
testing for every single person, they wouldn't be a company anymore.
No, but I
So,
agree with you. That's
yeah.
the direction. And probably even with some of my cancer therapies that by the end of my career, we'll see much more individualized approaches based
Right.
on genetic phenotypes. I mean, I was an early adopter of platelet-rich plasma just because I got excited about what our bodies can do to heal themselves. And so in combination, even with some of you guys' technology, it's amazing what we've been doing with PRP. But yes, medicine continues to trend in that direction to
Right.
where our therapies are not one size fits all. And I would assume assume that skin cancer is going to continue in that direction as well.
I bet you it. I mean, it must because of all the things you
Right.
listed that are factors in it.
Right. I mean, immunotherapies in addition, and we're talking about more aggressive skin cancers where I have to partner with an oncologist, but we're not just doing chemotherapy by any means. And you may know this from what you've gone through. We're doing immunotherapies to help your body do a better job at treating these more aggressive or metastatic skin cancers, because we know that not just wiping everything out with chemotherapy, but the oncologists are almost always pairing immunotherapies to help your body fight these cancer cells itself.
Yeah. And so let's talk more about the demographics.
Sure.
Do you, in your own practice, see more prevalence in any given demographic? Because Dallas, I'm not sure how diverse Dallas would be compared to somewhere more metropolitan like in New York City or in LA. But
Well,
what do
and
you
I'm
think?
probably even less metropolitan than Dallas. I'm in East Texas, so I service a really large rural population.
Okay.
And so I can say out of the 16 patients that I did surgery on today, 16 of them were Caucasian.
How
14.
fast are these surgeries that you did 16 of them?
Oh, we've got a huge, they're tiny. You cut it out. The longest part is that it goes to the lab. I wait an hour
Okay,
and then,
okay.
yeah, no. These are small. And we've got like 8 nurses working with us. It's a big to do, but, that's a pretty standard for a Mohs surgeon on a busy day. But, and 14 of the 16 were over 65. So that's my most common demographic in a more rural market is Caucasians over the age of 65. Now, one patient was in their 30s, also Caucasian, and had a history of sun exposure as well, of heavy sun exposure. And so we definitely see that. I mean, every once in a while, I'll see a pediatric patient with skin cancer, typically associated with different genetic syndromes as well there. But the vast majority are older, and that's because UV damage is cumulative. So you may have had most of your sun damage when you were younger and living in a tanning bed, but it's cumulative. And so is our ability to repair that DNA breakage. It goes away with time. We're not as good at it at 70 as we were at 20.
Right.
And so that's why that older demographic tends to be more common. That being said, I have African American patients. I have quite a few Hispanic patients as well with skin cancer. And so having skin of color does not completely protect you from skin cancer, both from UV radiation and for those other genetic causes as well.
Do you see any significant differences in prevalence between skin of color
course.
versus?
Yeah, absolutely. Like I said, if 16 out of 16 today were Caucasian, but I would say there's, a handful, 20 to 40 a year that are non-Caucasian.
Out of
several thousand.
okay,
Yeah.
so it's
but
pretty
again,
significant. But
I have a
it's
much
still
more rural market too.
That's true.
Where my diversity is a little bit less probably in rural East Texas.
Well, lucky for us, Ndashe did some homework and she gave
did.
us that, for instance, in Switzerland and Great Britain, they have a highest incidence rates. Scandinavian countries second highest, and Balkan countries have the lowest incidence. This is just in Europe, not
Right.
world. And so, what do you think about that? What do you think contributes?
So Europe's a little bit different, and that typically what we see is the closer that you get to the equator, the higher your incidence of skin cancer is in people with lighter skin types. But in Europe, you've got that reverse to where as you get closer down there, as you're getting closer to the Mediterranean, your skin's naturally getting darker. And so they do have more natural protection. And so that's why you see the higher incidence in the more northern countries. It's related to the skin type demographic. And actually England is a little bit interesting because then it reverses again because England has so much diversity among their population based on kind of history and the way that immigration happened, those type things as well. So England goes back a little bit different, but again, that's because their diversity is different. And so it goes back to that standard, the more southernmost see a higher incidence of skin cancer, but it's mainly related to skin type.
Right. Are you familiar at all with like the rates of skin cancer like in Australia or?
It's through the roof in Australia, and that's
because of the
because,
ozone, right?
yes, the ozone, and most folks have lighter skin types there.
I would like to know like the difference between like the Aboriginal versus.
I'm sure it's significantly less. Most of that Aboriginal skin is that beautiful type 5 and 6, so it really does have a lot of natural protection. But again, it wouldn't be 100% because
Sure.
specifically in darker skin types, what I'll see is nail unit melanomas, or sometimes what we call acral lentiginous melanoma, which means acral hands and feet. And so the problem is, number one, these darker skin types have a much higher threshold. They're not looking for skin cancer because they're not expecting it.
Right.
Number two, what we see is this more genetic predisposed type of skin cancer where it comes up on the bottom of your foot. When's the last time you looked at the bottom of your foot?
That's a good question.
Yeah, exactly. And so something can grow and be much more, be a much later stage because it's been growing there for a while and unrealized
Right.
when it's on the bottom of your foot.
Yeah. So how do you look for darker Fitzpatrick skin types when you're trained to look for dark spots that are changing borders and such? It must be
Right.
more challenging.
Well, I can't look if you're not in my office. And so that's first
Sure.
and foremost that
Yep.
sometimes if I'm doing a skin exam, then I'm looking between your toes. I'm looking at the bottom of your feet. We're doing that consistently every time. But if you're not in the office, then I can't see it and catch it. But if there's anything, typically those acral lentiginous melanomas too, they follow that ABCDE rule. If I see a concerning spot, but you can also look at that skin. We use a tool, and in our dermatology clinics called a dermatoscope with polarized and non-polarized light that you're
Okay.
magnifying these skin markings, and it's the way that the pigment sits in the ridges and the furrows of the hands and the feet that causes me to have a higher level of concern. There's different patterns that we look for there specifically with the hands and the feet, but again, if I can't see it, I can't
Yeah. So in
biopsy
a
it.
darker Fitzpatrick, would you use the same thing on a non-hand and foot area?
Typically
And
we
would it
do.
show up?
It's so typically I'm looking for the same type things. And history is really important in skin cancer too. I can't tell you how many times I say to, especially to my higher risk folks, like if you get what you think is a pimple or a bug bite and it doesn't heal up, or an inflamed hair follicle and it doesn't heal up after 2-3 weeks, especially head, neck, forearms, don't you keep it. You come see me earlier, because by now, the smaller I get things, the easier it is on both of us. But
Right.
all the time I hear folks that will say that it was like a pimple, it was like a bug bite, but it's still here 6 weeks later. And so it's the same thing in darker skin types. If you have a spot that's changing, a spot that's bleeding every time you dry your face, or a spot that you look and you say, that didn't used to be there,
Right.
all of those things, that's where history, sometimes in medicine we're like, ignore the history and just look at the patient in the lab test, those kind of things. I think with skin cancer, history is very important, because there's been times when someone says, hey, this mole is changing, I think it's totally fine, and I'm wrong. And so history to me should prompt me to biopsy as well.
Right. That's one thing that I told my father as well when he just got his pacemaker put in and such. He was getting a little worried. The doctor was saying it was okay, but at some point you have to realize you're the best health advocate you have for
Right.
yourself. Nobody is going to be as invested in your health as you. And so and I know that some people are hypochondriacs, and sometimes you have to kind of tell them, you're going to cry wolf too many times at some point. But, there has to be a point where you say, I know my body. This is not typical. So I need this checked out. Sometimes if you get resistance, that's why I asked that early on, is that some physicians might become resistant because simply they think you're being a hypochondriac or whatnot. That's where you get your second opinion.
Right.
Because I don't know, what do you get a lot of hypochondriacs where people are like, is this something or is this something?
For sure. We get that all the
Sure.
time, especially if you've had a history of skin cancer. All of a sudden, you
Yeah.
get really nervous about anything. And it can be like, I had one patient who had laser hair removal and they have a history of melanoma. They came in and all of their moles were darker
Oh,
because
yeah,
of laser
that's
hair
scary.
removal. But
Right.
she
Yeah.
was over the moon, freaking out that
Right.
all of her moles looked darker, but it was in the immediate aftermath of laser hair removal. The great thing about skin cancer and great thing about my job is that it's really, really easy from a diagnostic standpoint to take a needle, I numb it, I do a biopsy, and it takes me 10 seconds to do. And so if there's a concerning spot, it's very easy to diagnose. And in folks like that who have a low threshold and they're certain, like, this is changing, like I said, sometimes history is important. And that's where I'll do a biopsy, because it's quick, easy. It's not a very expensive procedure to do as well.
It's typically reimbursed too, right?
Oh, absolutely.
Yeah.
Absolutely. Yeah.
Because you don't only do cash out of pocket, like aesthetic stuff.
No. The vast majority, like I said, my real job's skin cancer. And so almost all of that, unless a patient's uninsured, is covered by insurers.
Right. Okay, so I think there's a couple more types here. You mentioned one of them, and I'm trying to find it. Was it the dermatofibrosarcoma?
That was kind of put in there. So let's put that in perspective. So
Okay.
dermatofibromatosarcoma protuberans makes you sound really smart when you say it correctly. DFSP is what we colloquially refer to it as. So where I'll see several thousand basal cell cancers a year,
Right.
I see one DFSP maybe every 2 years. So not common at all, but it's one that I see in younger patients. And typically folks will misdiagnose it as a cyst or dermatofibroma, which is a benign lesion.
Yeah.
But they grow and they can be very, very locally aggressive. And so really large tumors, not very common, but slightly higher incidence. And that's actually caused by a genetic translocation between chromosome 17 and 22. So it can
Interesting.
also just be a spontaneous genetic mutation as well.
So it's Indashe says that that's more predominant in skin of color, where basal cell is more in Caucasians. Is that something you observe?
Slightly so. I've seen it both. I mean, I've seen DFSP. Like I said, I've got my 10 to 15 that I've treated during my career of DFSPs, and I would say about half of them have been in African Americans. That's my personal experience. But because it's not a UV exposed cancer, it's a very different type of cancer. I wouldn't expect that same link with skin type that we necessarily see in those UV induced malignancies.
Okay. Angela, do you have any questions about that? Or anything in
No,
particular?
I'll go back to something that was said earlier, just kind of based on my own perspective and having gone through treatment at a well-known cancer center, but also exploring integrative oncology. So understanding, and for most people, I think would think of Dr. Dean Ornish has written a book called Undo It, and understanding that through diet, through supplements, through exercise, moving your body, through emotional health, through other means, how you can change the chemistry of your body to fight most diseases, including cancer. But I'm sitting here listening to you, Dr. Holman, and I'm questioning, is that true for skin cancer, though? Because it's something from the outside in. It's something that's affecting you from the outside, where most disease is starting from the inside.
So I would say that just like any other health process, the healthier that you are overall. Now, is it 100% against skin cancer? No, but your recovery afterwards, all those different types of things. So is there research out there that meditation prevents skin cancer? I don't know if those papers that exist.
And I didn't read it, and I was doing research for my own
However,
situation.
I would think just like anything else, we're one.
It's all connected.
It's all connected.
We're one person, and so
Right.
the overall health plays into that. Do I see somebody get sick for something else, and then they have a string of skin cancers that pops out? Absolutely, I see that all the time. Or they get in poor health for another reason, and all of a sudden I start to see these other skin cancers. We are one being in one body, and so I definitely see the converse of that. When folks aren't doing well,
I mean,
those skin cancers pop up.
Yeah, you've mentioned when you get stressed out, you have flares on your skin, right? Of some sort?
Yeah, I mean, that's mainly rosacea. I mean, I feel
Which is
flushed
an
and I
inflammatory
can
disease.
Yeah, see change in my skin.
Right.
Yes,
Right.
exactly.
So if we're equating inflammation to development of cancers, or kind of pushing it over the edge to become more aggressive cancer or something, that's all together. Somebody's constantly has anxiety or whatnot. So because right now in the book that's actually going to come out later in February than I thought, I'm not going to get too into that. My publisher just informed me. But we talk about the gut-brain-skin axis because that is important to note. I think a lot of people, and I'm not even sure. Let me ask you how you think about this. But when the way that I describe the human body is almost more like a tube than what people think of as inside the body and outside the body. Because the way that we develop as an embryo, it's actually we're a ball of cells, and then we kind of get invaginated, and then we become like a tube. And one side is what goes in our mouth, the other side is what goes out of our body, the waste mechanism. And so when I think of the body, I think of even in our guts, that's still outside the body. And so when you said it's an inside out, outside in, I actually think of anything that happens on the skin and in the gut, I think of very similarly. They're different environments, right? And they have different functions. But when I think inside the body, I think more like of truly inside the body, like inside the walls of a house. That's inside the house, really, where your living room is really outside the house. If you really think of it, it's just a different part of the outside of the house. And so,
but it all makes sense to me because what have we said over and over? That we're constantly experiencing DNA breakage, and we're trusting our own bodies
to heal it and
to
take care of
repair
it.
that, and to constantly keep things in check. And it's when that pathway doesn't happen that you get skin cancer,
and a lot of other cancers.
Exactly.
Inside, yeah.
And so same thing. Like if your microbiome is disturbed, does that impact your ability to repair that DNA breakage? Those kind of things. I mean, I completely agree that it's all tied together.
Yeah, and I think that's what maybe you're getting to is with the all-inclusive. You take the whole, and the holobiont philosophy doesn't just include the ecosystem as far as the flora, meaning the microbes. It's also your stress levels, your sleeping patterns, the foods you eat, the habits that you have, exercising. It's all inclusive. And for me, the biggest example of this philosophy and how I feel it plays into health and well-being is when I was doing my doctorate, and my mentor, my PI, said, you have to quit everything but science if you're going to be successful. And I really had to think about it because I didn't know if I wanted to be successful if I had to only do science, because a lot of my passions are in the arts or, in going to the gym or things of that nature. And I felt like And then I eventually came to the conclusion that I did not agree. That I felt that if you burn yourself out, if you're not well-rounded in all capacities, that you truly can't be the best form of you. And I think that comes down to why, some cancers may manifest because of a dysbiosis of some part of your life or your well-being. And I think we can even use metaphors for cancer, right? Where if you let things fester, if you're not well-rounded, and so I don't know, we're not going to get into that whole idea, but you know where I'm going with that.
Right.
But anyway, Angela, what else from a consumer perception of cancer and somebody that's kind of been through the ringer with another form of cancer, what would you think that the consumers that are listening that are not physicians or industry individuals might want to hear that we haven't already discussed?
I would just stress the part where you were saying advocate for yourself. Because from my own experience, I found my breast cancer and I had just been to my OBGYN. And she did not detect it.
She thought it was a scar.
Fortunately, I was called back into the office for another reason. And at that time, I said, I need you to examine again because I feel something. So you have to advocate for yourself.
You know your body.
And I love the idea, Dr. Holman, of, when you said, do you see a lot of hypochondriacs? But in skin cancer, don't you kind of want them to be a hypochondriac?
I 100% want them
Don't
to be
you
a
want
hypochondriac.
them?
For two reasons. Number one, if it's a melanoma, 90% of them we catch at a stage 0 or a stage 1, and it's a story like mine where it has not impacted the rest of my career or my life. I cut it out at 24. That was it. I get a once-a-year skin check.
Right.
Caught it early. 90% are that way. 10% can be scary. We're getting much better at treating melanoma with those immunotherapies.
Right.
But do the other side of that. So what did I spend all day today doing? Treating basal cells and squamous cells. The smaller that I get them and the smaller the hole that I put on your nose, the less laser work that I'm going to have to do down the road to really kind of blend my scar in. And, because the larger it is, then I get into having to do larger flaps and skin grafts and those kind of things as well, which we do if we need to. But if we can catch them small, it's a tiny side-to-side closure for the patient. That means a much more aesthetically pleasing scar.
Yeah. So, that would be the main thing is just if you think it, act on it. If, it's that moment that you can say, well, that's interesting. And then you start to kind of brush it off. I would say don't do that.
Right.
I would say go to the office and have it checked. And then just prevention. Looking from an industry perspective now and what we do every day and the antioxidants and the sunscreen, that's Crown Laboratories started as a sunscreen company. That's what we do. And then, of course, on the medical aesthetic side, antioxidants and going big into that discussion now with the skin microbiome and what we're doing in that side of the business. there's opportunities that young patients can be taking advantage of now that allows them never to have to go down that path and end up in one of your, surgeries every morning.
I would be remiss as a dermatologist on a skin cancer podcast if I didn't say your sunscreen's a daily thing. It should be at least an SPF 30 and broad spectrum. That number that's there is your UVB, so you need to make sure it's broad spectrum. And most of our sunscreens and sunblocks are broad spectrum as well. And if you're out, I don't care if you put on an SPF 100. If you're out all day, you still need to reapply every 2.5 to 3 hours, especially if you're exposed to the water.
Yeah, probably it's better to put a lower number on more often than a higher number once.
I say for sure it is. I say beyond a 30, like if you'll use it, I'm cool with it. Like get your number if it's beyond a 30 and you're doing the appropriate reapplication and physical protection. There's no substitute, like
Clothing,
I said, for my giant umbrella hat.
Yeah.
Right.
Yeah. So, but yes, reapply.
Yeah, I think for people like you might be going to the beach just because you want to enjoy the beauty and be outdoors, the fresh air. A lot of people, they're specifically going to get tan.
For sure.
And so that's, again, it's just the philosophy of why are you doing that to your body? You can still enjoy nature without putting yourself at risk. And interestingly, just to end it on my part, you're talking about advocating for yourself. Well, I've always been a little bit because my mother passed when I was very young from cancer. And so I've always been very skittish about anything that I think is at even possibly cancer. And I remember there was a spot on my back, and as you can't really see right in the middle of your back very easily, of course I'm like, I need somebody to watch this. And I remember I went, I thought it was getting larger, and so I went to my general practitioner and asked them to please remove it. No, it was a dermatologist, I believe. And they didn't do it, but they had a surgeon on staff that was going to do it. And the surgeon basically tried to talk me out of it. And then when she was stitching me up, she was almost chastising me because my skin was too thick and it was giving her trouble closing it up. And came back as a precancerous. Now, of course, that didn't mean I was in any inherent danger,
Right.
but it was one of those things where it's like, I almost felt bad for putting them through that when it was like, no, I needed to look out for myself. And so that's one of those things where I'm kind of wondering, is it really that big of a hassle, or is it just because that's not their typical thing that particular practice did, where you're doing it all the time? So maybe
Right.
for you, you're like, yes, do it.
Right. So I am a surgeon. So if you
yeah.
came into my clinic, it wouldn't be a big deal for me, like in the middle of clinic, to stop and cut something out.
Right.
But not all dermatologists are surgeons. And
Right.
so they may want to do a biopsy or have you set up back with someone else who could do an excisional biopsy if that's necessary. And so expectation should not be across the board that all dermatologists are surgeons. We're all skin doctors.
That's right. There's
But,
specialties
right,
within it.
but
yeah.
not all of us. Like I said, I have a second board certification in dermatologic surgery as well. So that's a subset of our specialty.
And I guess if you're cash only, you probably are less wanting to deal with any, because you're not going to get reimbursement, and so then you might want to refer.
Right.
So I guess it's one of those things where you just need to know why you're going to where you're going, so that you're not asking for the wrong thing from
Right.
the wrong person. No, all right. Well, Jenny, thank you so much for
course.
joining us, Dr.
Yeah.
Holman. You're going to stick around for a brief discussion on skin barrier in a bit.
Can't wait.
All right. So is there anywhere that you want the listeners to look for you? Any social media or anything like that you want them to know about?
It's calm.tyler is our Instagram handle. There's a lot of really silly things out there, like me filming a cool sculpting ad while I'm waiting to do a podcast. But no, we just have a lot of fun and talk more about the cosmetic things we do there.
Okay. And Angela, what about you? Where can they find you?
On Instagram as well.
So you have 2 posts now.
But they're both related to BioJuve. So
That's
you
wonderful.
Can't complain,
No,
right?
I can't.
Yes, I have to admit I'm not very active, but Angela
This is
Wilson
the year.
McDonald on This is the Year.
Yep.
I have vowed to be more active because I'm so excited about what we're doing professionally that I want to post. And I'm sure that's the same as what you feel. You have such a passion for what you do every day. That's the reason that I want to be active on
All right.
social
Well,
media.
so I think we should get some of the Skin Science podcast posts on your Insta.
I'll start tomorrow.
All right. And again, I'm Dr. Thomas Hitchcock. You can find me at dr.t.hitchcock on Insta, or you can go to my website at dochitchcock.com if you want to see some of the things I'm writing, things that I'm doing, or see some of my puzzle solve videos, which is my hobby, which, trust me, it's probably more fun for me than it is for you. But anyhow, we hope that you enjoyed today's podcast. Thank you for your eyes and ears, and we hope you gleaned something from this. And until next time, goodbye for now.